Ebstein's anomaly of tricuspid valve is a condition in which the septal and posterior tricuspid leaflets are displaced distally so that a portion of the right ventricle becomes atrialized. The tricuspid valve in Ebstein's anomaly can have severe regurgitation or stenosis, both of which leads to enlargement of the right atrium. As part of the right ventricle is taken away by the right atrium, right ventricle is small in Ebstein's anomaly. Sometimes there is an associated atrial septal defect. As the pressure in the right atrium is usually higher than that in the left atrium in Ebstein's anomaly, blood shunts from right atrium to left atrium. ECG in Ebstein's anomaly of tricuspid valve showing right bundle branch block pattern with polyphasic and splintered QRS. The QRS is wide and lead V2 shows RS-RS pattern mimicking right bundle branch block. Lead 2 shows multiple small deflections, splintered QRS. The slurred S waves in lateral leads also form part of the RBBB pattern. Splintered QRS is called fragmented QRS according to a new terminology. Fragmented QRS has been shown to be associated with larger region of atrialized right ventricle and increased risk of arrhythmic events in Ebstein's anomaly. They also had more severe tricuspid regurgitation. The extent of fragmented QRS is measured by the number of leads showing the FQRS. QRS duration is longer in those with FQRS. Those with increased QRS duration have a higher mortality on long-term follow-up after corrective surgery. The duration of QRS has been linked to right ventricular enlargement and dysfunction in Ebstein's anomaly. A larger atrialized right ventricular volume has been noted in these cases. As a corollary, those with near-normal ECG would have mild morphological abnormalities and a better clinical profile. Ebstein's anomaly may be associated with right-sided accessory pathway in ventricular pre-excitation, WBB syndrome, with or without atrioventricular re-entrant tachycardia. Multiple accessory pathways can occur and radiofrequency catheter ablation is effective, though sometimes challenging. Tall P waves due to gross right atrial enlargement in Ebstein's anomaly have been called Himalayan P waves, though not seen in the ECG illustrated here. Developmental anomaly of the tricuspid valve is associated with delayed intra-atrial conduction, right bundle branch block, and accessory atrioventricular pathways in Ebstein's anomaly. In a series of 224 patients, 28% had documented tachycardia. 33 with recurrent tachycardia had a single right-sided accessory pathway which was successfully ablated. Only 21 of the 33 patients had typical ECG pattern of pre-excitation. An interesting finding was that none had an ECG pattern of right bundle branch block during sinus rhythm. Radiofrequency catheter ablation resulted in the appearance of RBBB in 94% of patients. Absence of RBBB in patients with Ebstein's anomaly with recurrent tachycardia had 98% sensitivity and 92% specificity for the diagnosis of an accessory pathway. WBB syndrome results from pre-excitation of the ventricles through AV bypass tracts or accessory pathways. Accessory pathways are muscle bundles which connect the atria to the ventricles electrically across the mitral or tricuspid annuli or through the septum, crossing the atrioventricular insulation provided by the fibrous skeleton of the heart. Pre-excitation occurs because the impulses reach the ventricle, avoiding the physiological delay in the AV node. This produces shortening of the PR interval and an equal widening of the QRS complex with a slurred initial wave called as the delta wave. As a general rule, the delta wave points away from the site of insertion of the accessory pathway into the ventricle as the initial conduction proceeds away from that site. Hence, a positive delta in V1 indicates a left-sided accessory pathway and a negative delta in V1 indicates a right-sided axillary pathway. When the pathway inserts in posteroseptal region, almost all the precordial leads show positive delta waves and inferior leads show negative delta and QRS complex, overall resembling an infraposterior infarction. When the pathway inserts in the lateral wall of the left ventricle, the negative delta wave in lateral leads resembles a lateral wall myocardial infarction. Varying QRS width in WPW syndrome due to varying degrees of pre-excitation is known as concertina effect in WPW syndrome. The more the pre-excitation, the shorter the PR interval and wider the QRS duration. Features suggestive of WPW syndrome in this ECG are short PR interval and delta waves. In lead 1, delta wave is almost isoelectric and pre-excitation can be missed. Delta waves and QRS complexes are negative in AVR and AVL, while it is positive in all other leads. Since there is left atrial enlargement in this ECG belonging to a nonagenarian, there is every chance of development of atrial fibrillation. Accessory pathway localization. Left lateral pathway, as there is negative delta in AVL and V1 to V6 are positive. Repeat ECG after 3 days showing disappearance of pre-excitation. No pre-excitation is seen in this repeat ECG, meaning that there is no conduction through the accessory pathway. Initial deflection in lead 1 and AVL are positive. R by S in V1 is less than 1. That would mean the absence of two most sensitive indicators of anterograde conduction through left lateral pathway. This can happen due to 3 possibilities. 1. Block at accessory pathway. 2. Intratrial conduction delay as suggested by the notched P wave in lead 1. Or accelerated conduction through AV node akin to the disappearance of pathway conduction with stress test. The last one is not applicable here. The initial 2 cannot be differentiated in surface ECG. Of course, some soft pointers may give some clue. 1. If an atrial premature complex from left atrium results in pre-excitation, second factor is negated. 2. Notched P wave has been suggested as an evidence of interatrial conduction delay or delay at Bachmann bundle. Left lateral pathways are well known to have no pre-excitation on surface ECG due to some of these reasons and may manifest with atrial pacing only. Then it is known as latent pre-excitation. This ECG has a superficial resemblance to left bundle branch block with tall slurred QRS complexes in lateral leads. The QS complexes in inferior leads mimic inferior wall myocardial infarction. Actually, it is a non-infarction Q wave or pseudo-infarction pattern. The PR interval is short and is immediately followed by the slurred initial portion of the QRS in lateral leads, which is the positive delta wave. These features are suggestive of ventricular pre-excitation as in WPW syndrome. The delta wave is negative in inferior leads and V1. The tall QRS in lateral leads also mimic left ventricular hypertrophy. Mahaim fibers are a type of accessory pathways connecting the atria to the fascicular conduction system in the ventricles. Nodovascular pathways have also been described. Mahaim fibers have decremental conduction properties like the AV node. No delta wave is usually seen in sinus rhythm with Mahaim fibers, though it is a form of pre-excitation. Mahaim fibers do not conduct retrogradely, so Mahaim fiber tachycardia is always with wide QRS complexes, antidromic with RBBB pattern. The fibers are usually located around the tricuspid annulus. Typical Mahaim fiber tachycardia has a left bundle branch block morphology with left axis deviation and a late precordial RS transition. Lown Ganong Levine Syndrome is one of the pre-excitation syndromes like the better known Wolff-Parkinson-White WPW syndrome. The electrocardiographic finding is a short PR interval with normal QRS duration, unlike the wide QRS in WPW syndrome. The description by Lown B, Ganong WF and Levine SA was in 1952. Lown B et al. In their paper report that 11 such cases had been reported earlier. The earliest among the cited papers was in 1921. In the seminal paper, Lown et al. Observed that out of the 200 patients with short PR interval, 23 had paroxysmal tachycardia, 11%, compared with 0.5 to 1% in a control group of 200 patients with normal PR interval. Among their group of 200 patients with short PR interval, 184 had normal QRS complexes and 16 had WPW pattern. The incidence of tachycardia was 25% in those with WPW pattern and 10.4% in those without a wide QRS. Of the 23 patients in their group with paroxysmal tachycardia and short PR interval, 82% had a normal QRS complex and 18% had features of WPW syndrome. They noted that those with short PR interval, normal QRS and paroxysmal tachycardia, LGL syndrome, were predominantly females. The tachycardia in half of them started in the 4th decade of life.